All right. Hi, everybody. So for those that don't know, my name is Nicole Stupak. I have been a PA now for almost 10 years. Graduated from Barry University 2015. I currently work in 6 specialties. Well, technically internal medicine is my home, core training, emergency medicine, but working also with experience in infectious disease, interventional radiology, and the surgical ICU. My former life, I was an ultrasound tech, and honestly, that created the foundation towards becoming a PA, and actually had given me this unique perspective that my students over the years have encouraged me to teach, especially online. So this is new. I apologize for the hiccup earlier. This is definitely a learning in progress here. So I tried to post, for those that don't know, or if you tried to go there already, I tried to post earlier on YouTube, but apparently I need 50 subscribers to be able to do that. So, sorry. So here I am. I figured this would be a good little backup. So for those that saw the little ad that went out earlier about cough, and a cough being not always the diagnosis that you think it is. So let's break this down. The reason that I have chosen to do this is because I feel that there is an unspoken bias in medicine, and not just in medicine, but in life. You know, we all see things and everything is from our own perspective, our own experiences. So, you know, when you go to school and you go through your medical training, regardless of what it is, whether it's respiratory therapy, nursing, physician, PA, nurse practitioner, it doesn't matter. You're taught a standardized way of seeing the patient, approaching differentials, diagnoses, and all of that is absolutely valid. And all of that is needed. But what ends up happening, at least in my own experience that I've seen, and even in life too, because if you think about it, I guarantee you that there is an unintentional bias that we apply to our own lives. So what ends up happening is we end up having this, what I call a tunnel vision. So take a chief complaint, i.e. cough, right? And 5 top differentials. What are they going to be? Your 5 top differentials is going to be postnasal drip. It's going to be GERD. It's going to be pneumonia, bronchitis, right? So your typical GI, pulmonary kind of things. What if I told you a stroke could cause a cough? That could be, what? What are we listening to? Who is this crazy lady that, is here? So going from what I was speaking about earlier with my prior experience as an ultrasound tech, I have had more anatomy and physiology classes than I can think of. So when I see the patient and I approach the patient, I take my amazing foundation that I've already learned and everything that these schools have taught us, but I also apply my prior knowledge of anatomy and physiology. So if any of you guys have ever seen The Good Doctor and you see how he's like with his mind's eye and he puts all these, he sorts out the problem. I make jokes with my students all the time. That's how I see the patient and the situation based on the information that they tell me. So how does this apply to the patient? Well, okay, school will teach us, well, history teaches us too, but school teaches us that history is everything, right? That is true. I'm going to agree to that. History is 100% everything, but I'm also going to argue that because history is only as good as the person asking the questions and only as good as the person answering those questions. And just because you ask a certain question doesn't mean you're going to get the answer you want or need. And then just to throw fun on that doesn't mean that their meaning of that word is yours. So pain, perfect example of that, right? Pain can be pressure. Pain can be, weakness. Pain can be sharp, dull, stabbing, radiating, all these different features. So now that complicates things, right? So how do we really know what it is that the patient is telling us? So you have to listen and you have to see with everything. You take in all your details. Early on in my training, even as a sonographer, I worked with some pretty remarkable physicians, and they basically said, you have 30 seconds to figure out what your diagnosis is. I nearly had a heart attack when I heard that because 30 seconds is 30 seconds. How are you going to be able to put all that information into 30 seconds? Well, it's easy. You creep. You literally become a creep. You look at all the details. You take in all the information. And information is not just verbal. Information has to do with eye contact, cues. Are they diaphoretic? Are they, appearing anxious? Are they tachypnic? Are they in distress? Are they, do they look uncomfortable with the person in the room? So information is all of it. It is a comprehensive package for you to be able to create your diagnosis with your patient. Now, going back to bias, it is unfortunately something that has become very familiar and mostly unintentional. And one of the things I've been working on a few projects is to help to improve this bias, this provider-patient relationship. So physicians, PAs, nurse practitioners, nursing, certain situations will make you feel a certain way, and the patients too. They come in and they feel like if they're asking for pain medicine, all of a sudden they're being judged. And that shouldn't be, right? So if you take all of your life's experiences, everything that your schools have taught you, plus probably the most important pieces is everything that undergrad has taught you, and you put all of that together with all of the information that the patient gives you, in addition to their families, then you'll be able to see the picture. Rather than just focusing in on a cough, having it be here, right? So now, if we have a patient and that patient comes in with a cough and that patient says to you, my cough gets better laying flat. That's weird, right? That's a weird thing to say. What cough gets better laying flat? An outpost nasal drip, definitely not that one. It's definitely not GERD either. So what? How is that? How is that? So now you got to say, okay, this is a piece of information that's a little weird, or do you dismiss it? Is it an outlier because it's an outlier, or is it an outlier because it's part of the important piece of information that you need? So how do you decipher all these things? How do you end up coming up with the diagnoses? How do you come up with the treatment plan of the patient? How do you know that they're even telling you the truth because of everything else I've already just said? And I don't mean truth as in lies, but truth to see the diagnosis for the patient. So when I see the patient, I truly look at them from anatomy and physiology, and I don't make something stick that doesn't stick. If the information seems off and it seems odd and it seems like it may not fit, it may not, but it doesn't mean it needs to be dismissed either. So going back to the same patient with the cough that gets better laying flat, well, let's just say his entire physical exam is normal. Well, physical exam of what? What are we examining? If you think to yourself, and you're a medical provider, or you're in medicine and you are an MA or a nurse or whichever, and they come in, what's part of your exam with a cough? Are we just doing heart and lungs? We opening the mouth, looking at post-nasal drip, any enlarged, cervical lymphadenopathy, any tonsil enlargement, any of these things. So what if I told you abdominal exams should be included into that? Why would I put that in there? And then with a cough getting better laying flat. What? How could this possibly be? So, in my mind's eye, going back to the Good Doctor show, I keep the anatomy in my mind. And anything along that course of the phrenic nerve is up for grabs. So going way back to undergrad, which I honestly humbly feel are the most important classes because it definitely sets your foundation to have an understanding of the different things and putting all the pieces together. But if you go way back to undergrad and you remember your anatomy and physiology class and how stressful everything was because you were trying to get into whatever program it is you're trying to get into, and you see that the phrenic nerve, you're learning about the thoracic cavity, you're learning about, your cervical spinal nerves, you're learning about pericardium, learning about neurology, learning about the abdomen. So how would the cough get better laying flat? So, well, if you think way back there, the phrenic nerve is a sensory nerve and it's a motor nerve. Its primary function is for inspiration in the thoracic cavity, correct? But it goes all the way down into the thorax, superior pharynx, and then in the abdomen you have your inferior pharynx. The sensory aspect of it collects information from the pleura, your pericardium, and the peritoneum. And the motor allows your diaphragm to increase and decrease. So when I say anything along the course of the diaphragm can give you a cough, then peritonitis is definitely up for grabs, right? Pericarditis is up for grabs. Endocarditis is up for grabs. So your differential lift for cough just filled the room. So when you see the patient and you ask them, why are you here? Remember to keep the answer or the questions open-ended so they give you an open-ended. You want them to tell your story, their story, so you can put all the pieces together. Because if you go in there and you say, how many days? What is it like? Is it radiating? What are the characteristics? You're just going to get those answers. And you may or may not be able to put all these things together to come up with a diagnosis. So what if I told you that same patient went to some other places and got 2 Z-Packs, got Tesla pearls, got an albuterol inhaler, got steroids, got all these things, and nothing worked? What are we still going to do? Are you going to still are you going to get a chest x-ray? Are we going to examine the patient? What would you do? You still keep throwing things at the same thing? If you have a diagnosis and the treatment, for the most part, there's some exceptions, but for the most part, cough, you treat the cough common things. It's not working. It's probably not the cough common things. So we have to expand. Ideally, you want to always keep your differential list flowing. Now, unfortunately, the way that medicine as a whole has become is there are just not enough of providers. There's so many patients, insurance companies and things and this and that. And people can feel overwhelmed on both ends. The patient, the providers, the staff. So are you listening to them on both ends? Patients and providers goes both ways. So patient comes in, they tell you, I'm here with a cough. What makes it worse or better? Laying flat. Okay. Weird, right? Lungs are clear. Oropharynx clear. Nose, maybe some septal deviation, a little, enlargement of the turbinates, but otherwise unremarkable. So what do? What's your next thing to do? Oh, here's an inhaler. Oh, here's some Tesla pearls. Person comes back the next week, same thing. But what if I told you now that a person goes through all those things, then they come back, maybe you're the 3rd person, 4th person they've seen, and BP stable, heart rate 152. What would you think to that? A little weird, right? Because in our mind's eye, when we're taught things, one of the other things I think we do is the assumption is, especially early on in the career, is a disease course, a disease process. You think that it literally happens like from one day to the next. But the reality is actually these things take time. So depending on time in between the variety of treatments, you're going to get a different set of vitals. You might even get normal labs. You may even have normal imaging. But your physical exam is never going to lie to you, ever. So I challenge each of you that are medical providers that are seeing patients, and even patients with providers, keep things, number one, don't ask yes, no questions. Keep everything to where it's a conversation. Take the time, listen to the patient, listen to the provider. And providers do your exams. Imaging, I don't know. I have a lot of feelings about AI and all this technology and stuff, but The physical exam is never going to lie to you, ever. If you are too early in a disease course, you are going to have normal everything, labs and imaging. So then what does that mean? Does that mean that it's not there? Or does that mean it's just too early? So always see the patient as if nobody's ever seen that patient. Even if they've been to 25 different people, it doesn't matter. Start from the beginning, start over, because maybe information that comes to you is something new that the patient just remembered. And again, certain things won't show until they're ready to show. So what if I told you the end diagnosis of that cough was actually a microperforation at the distal esophagus with peritonitis and abscess? Does that 152 heart rate look a little different? It does. So that 152 heart rate now, for those that are training to be soon on board, why is that 152 heart rate there? The body's on some sort of stress. But what if you walk up to the patient and the patient's just sitting there and they're on their phone and hanging out and look completely comfortable? Does that mean they don't have peritonitis? And the heart rate's 152. Does that mean they're anxious? Does that mean it's not anything in the belly? Does that mean that it's not anything in the heart? No. So what if I told you that patient comes in, chief complaint cough, no other symptoms, gets all of the things for the cough, you get your albuterol, Tesla, Z-Pak, and treats the things, now doesn't get any better, goes back, now gets some Flonase, but still has a cough. Told it was postnasal drip, told it was bronchitis, told it was reactive airway, told it was GERD, still has a cough. Does all the things, does all the cough. But then what if I told you shortly after using the Flonase, that person is now getting floaters? They go to the ophthalmologist and the ophthalmologist says, oh, it's the Flonase. You got to stop the Flonase. Stops the Flonase, but still having a cough. And the floaters are still there. So then what? Is it related? What do we do? How do we address this? Are we looking at it from a segmented, situational, this person's already saw you, so maybe it's not that anymore, or maybe we need to see something new, or do we start over and look at the whole thing and follow the timeline? My humble opinion, follow the timeline. Start over every time. Don't ever assume. And it's not because someone did something wrong before. It's not about that at all. It has everything to do with the information that presented itself at that time. You can't make the assumption that someone else heard and saw the things or told all the things, because maybe they didn't. Maybe they forgot. Maybe it wasn't there yet. So it's never judgmental on another person or anything in the past. You never want to do Monday motor quarterback, because that's not the way to practice medicine. And it's not the way to get the answers that your patient needs. So what if I tell you then shortly after that, now that person has atraumatic low back pain? Are they related? I'm going to challenge you. If you were listening and here from the beginning, and you heard that I function and do all the things from the anatomy and physiology, is there a connection between here and the low back? Yes, 100% there is. That connection is cardiovascular. Now you're like, wait a minute, what is this? What? Where's she going with this? Is it related? Or are they all three separate things? Well, let's take a guess or work it out. We had the cough treated with all the GERD things, didn't work. We had the cough treated with all the pulmonary things, that didn't work. Then we go to the nose things, that didn't work. And now we have symptoms below the diaphragm. I was taught by some pretty amazing attendings over my career that things that are above and below the diaphragm that don't seemingly make sense, most likely cardiovascular in some way, shape, or form. So the person, let's say, now goes to the primary or wherever urgent care, and that person says, you know, we did an x-ray and the x-ray is normal, let's go to physical therapy. Person goes to physical therapy, still has a cough, still has a floaters, still has a low back pain that doesn't go away. But now has atraumatic ankle pain and calf pain. Are they connected? Maybe. So person goes to some place, they say, okay, I want you to go now to get an ultrasound, rule out blood clot. Is it reasonable? Sure. And listen, calf pain? Yes, absolutely, especially if they have risk factors. So, but what else do we need to know? Was the skin looked at? Skin, huh? What do you mean skin? Why do I need to look at the skin? Well, can give you a hint to certain things. So, pulmonary things, still coughing. Nose things, still coughing. Floater things, still coughing. Atraumatic back pain, despite physical therapy, still coughing, still have pain. Now we have a new pain. What if I said they had a little petechial rash on that calf? Wait a minute, what? This just changed the whole picture. What if I told you that person went for emergent open heart surgery for an endocarditis? So, chief complaints are not always what you think they are. You have to see the whole picture. So, this is a little teaser video of what we're going to be getting into and what the Phoenix Lens method is about. Is seeing the whole picture, utilizing our life experiences, everything we've been taught, and applying all of those things to the patient. Hearing what they're saying, and not just what they're saying, but is what they're saying matching the rest of it? Does it match? Is it an outlier, or is it important information that needs to be considered? So, I hope everybody enjoyed this. There's a lot more fun to come. I kind of, like I said, a little spontaneous. This is very new for me. So, fingers crossed you guys enjoyed this. And all of the cases, all of the things that we're going to do, the goal is to get you out of that pigeonhole that we end up going into during training. Because sometimes things are not always what they seem to be. And it's funny because, you know, I've had my attendings that I work with, and, you know, they kind of laugh at me a little bit. And some of them have told me, you know, the easy things I, you know, can be a little flaky on. And that's probably true because I function from the anatomy and physiology perspective. I see every patient that way. So it will never steal your wrong. Never. And even information like the Krebs cycle, I probably just made some people a little like, oh God, the Krebs cycle. But all of that is pertinent. And all of it needs to be applied in certain situations with the patients, depending on the answers. So I hope to see you guys soon. And thank you for joining.